Mama said, fulfill the prophecy, be something great. Go make a legacy, manifest destiny. Back in the days, we wanted everything, wanted everything. Mama said, write your biographies, rewrite your history, light up your wildest dreams, museum victories. Every day, we wanted everything, wanted everything. Mama said, don't give up, it's a little complicated, all tied up, no more love, and I'd hate to see you waiting. Had to have hopes, I was living, shooting for the stars, but I couldn't make a killing. Didn't have a time, but I always had a vision, always had hope. Had to have hopes, I was living, didn't know how, but I always had a feeling I was gonna be that one in a million. Always had hope. Mama said, something for oddities, stranger possessed. They never wanna be the winner, the novelty. Don't ever change, we wanted everything, wanted everything. Stay up on their rise, stay up on their rise, and never come down. Oh, stay up on their rise, stay up on their rise, and never come down. Mama said, don't give up, it's a little complicated, all tied up, no more love, and I'd hate to see you waiting. They say it's all been done, but they haven't seen the best of me. Hey, hey, hey. So I got one more round, and it's gonna be a sight to see. Hey, hey, hey. Had to have high hopes for a living, shooting for the stars when I couldn't make a killing. Didn't have a dime, but I always had a vision, always had high hopes. Had to have high hopes for a living, didn't know how, but I always had a feeling I was gonna be that one in a million. Always had high hopes. Had to have high hopes for a living, shooting for the stars when I couldn't make a killing. Didn't have a dime, but I always had a vision, always had high hopes. Had to have high hopes for a living, didn't know how, but I always had a feeling I was gonna be that one in a million. Always had brainstorm, take me away from the norm. I got to I can hold my breath. I can bite my tongue. I can stay awake for days if that's what you want. Be a number one. I can fake a smile. I can force a laugh. I can dance and play the part if that's what you ask. Give you all I have. I can do it. I can do it. I can do it. But I'm only human, and I bleed when I fall down. I'm only human, and I crash and I break down. Your words in my head, knives in my heart. You build me up and then I fall apart, 'cause I'm only human. I can turn it on. Be a good machine. I can hold the weight of worlds if that's what you need. Be your everything. I can do it. I can do it. I'll get through it. But I'm only human, and I bleed when I fall down. I'm only human, and I crash and I break down. Your words in my head, lies in my heart. You build me up and then I fall apart, 'cause I'm only human. I'm only human. I'm only human. Just a little human. I can take so much till I've had enough. 'Cause I'm only human, and I bleed when I fall down. I'm only human, and I crash and I break down. Your words in my head, lies in my heart. You build me up and then I fall apart, 'cause I'm only human.
All right. Good morning, everybody. How are we doing today? All right. I'm going to kind of go slow because we're still waiting for a bunch of people to kind of pop their heads in here. So, did you guys have a good 4th? Anybody do anything fun?
Went to clinical.
On Monday? That's insane to me. I can say that now. That's insane to me. Did you see anybody blow themselves up? Any burns?
No, I was in the cardiac unit.
Oh.
So no, I wish I would have been in the ER. That probably would have made it worth it to see what comes in the ER on the 4th of July. But
A lot of stupidity, a lot of here, hold my beer moments, and not just fireworks, but just people being dumb, because people are dumb. Job security. But anytime on Facebook or TikTok, yep, job security. That's all I can say. Yeah, it rained on the 4th of July here, so didn't do too much here either. I graded most of the day and watched TV in between, and that was it. So nothing too crazy. All right. Well, so this week, you guys have your APA paper due. I'm finishing up your presentations. Your guys's should be, everybody should get theirs back by tomorrow. I'm trying to like push through these really quickly. So you have that. If you have questions on APA, make sure that you're reaching out to the CTL, because that's the biggest issue that I'm finding. It's not the writing, it's not the content, it's your formatting. You guys saw the template that was posted. Use that to help you at least get your headers and your title page correct. But if you're having issues with the references, definitely just pop by and be like, hey, can you look at this? And they will. So, and then you have your, what's that called? ATI, 2 Sundays. Sorry, I'm still tired from yesterday. I subbed for Professor King, and it was like 7 hours of talking, and I'm still making up for it. What else was I going to say? So Dr. Peterson is going to be taking over for the class next week. You'll see all the links get deleted today, and then he'll put in new Zoom links. It's going to be in the same spot. It's just going to be going to his Zoom and not mine. So you'll still access the class in the same way. And then the Professor Kanan and Professor King are working out the review for next week. It'll probably be Monday or Tuesday again. So the students going to the destination clinical can have that before they leave, or they take their exam on Thursday, because they take it early because they're going bye-bye. So watch the announcement for that. Somebody will post that. Other than that, anything else?
Is it true? I think someone mentioned that like you might be willing to open up some of your old like YouTube videos for us to watch, like for reviews or classes. Is that possible?
I did one from each of the remaining lectures this morning, so they'll probably be before the ones that you can see before week 1, because they're from last semester. So it's hard though. I'm gonna bear warning, the diabetes and the obesity units are flipped weeks, so there's downtime. The beginning is more of the review and stuff like that, so keep that in mind. And then the GU and the skin are normal weeks. So they're there.
Thank you so much.
You're welcome. All right. Well, if there is nothing else, we can go ahead and get started with our second week of GI stuff. So this week we go into the disorders of the upper and lower GI tract. Last week we talked more about the diagnostics that were going on. Hold on. Okay, so we talked more about like the diagnostics and the assessments, and now we're going to kind of put them into place. So we're going to start with where the GI tract starts, which is where? Just point your mouth. There we go. So we're going to start with the mouth, and we're going to kind of just work our way down. So looking into the mouth, there's 2 big disorders related to the mouth. The first one being herpes simplex virus 1. This is also known as what?
Cold sores?
Cold sores. That's what they are known as. So HSV1 is transmitted by oral to oral contact to cause that oral herpes infection. The HSV1 virus will be in the sores, in the saliva, and the surface in or around the mouth. However, HSV1 can be transmitted to the genital area through oral genital contact and can cause genital herpes. HSV1 and HSV2 are two different viruses, but we can have HS1 filled lesions in the genital area. So moral of the story is, if it's open on the mouth, don't go down south. Okay. So HSV1 can be spread from oral to skin on what appears normal. So just because there isn't an open lesion doesn't mean you can't transmit it, but it's less likely. You are most likely to transmit the virus when you have an open sore. When there's nothing on your face and nothing going on, your body is continually shedding the virus. But again, the greatest risk for transmission is when there are active sores. So after the initial infection, the blisters or ulcers can periodically occur. And there is sometimes no rhyme or reason why they occur. The frequency of reoccurrences varies from person to person. Some common triggers are stress, illness, menstruation, surgery, but it is important to know that this is forever. This is why we don't want people kissing babies, because mouths are nasty and we don't want to infect a baby with, this to have for the rest of their life. This does not mean that somebody is dirty or contaminated or gross, but they came in contact with that virus in some point in their life. So with HSV1, when an outbreak occurs, there's going to be some mild itching in the area, and then the painful vesicles kind of occur. The open sores can hurt. So we want to avoid things like spicy foods and citrus, because these can really aggravate the open area. The prevention of the spread is extremely important. No kissing with open lesions, no oral sex, and then treatments will include things like anti-inflammatories and over-the-counter ointments. Acyclovir is an antiviral that can be used with really significant cases, really painful cases, to kind of help with the outbreak. Then the other oral disorder is going to be candidiasis. This is thrush. Oh, sorry. What's up, Ethan?
So would people that are on immunosuppressant medications like methotrexate, would they have more flare-ups of like oral herpes?
It is very possible, but again, everybody's different. Some people get them seasonally, some people get them all the time. It depends on their triggers, and there's no rhyme or reason as to why an outbreak will occur. It's a good question. Okay. So candidiasis, this is thrush. This is a yeast infection in the mouth. It looks like cottage cheese. It doesn't hurt, but it's not pleasant. The most common pathogen is the Candida albicans. High-risk patients for developing this are going to be older adults, your immunosuppressed, like your cancer or HIV patients, people on long-term steroids, and people on inhaled corticosteroids. This is why we swish and spit after the inhaled corticosteroids, because this is what can form. Again, it's not overly painful, but it's not pleasant. The treatment for candidiasis is going to be nystatin, a swish and swallow. But teaching will be important here. Oral health, brush your teeth, get a new toothbrush. We don't want to be recontaminating yourself with your dirty, funky toothbrush. And making sure that they are rinsing after corticosteroid inhalers. Other education that goes along with this is just taking care of your mouth. No, we're not dentists, but we should be brushing and flossing as much as possible. 3 times a day is a little extreme if you ask me, but at least twice a day, bare minimum, once in the morning, once in the evening. Chlorhexidine is a prescription mouthwash that can be used to help prevent infections. Our goal is to prevent infections. We want to lower the bacteria in your mouth. Your mouth is nasty, everybody's mouth is disgusting. There's tons of bacteria that lives in a mouth. If you have a crack in your mouth or a broken tooth or an issue with your gums, all that bacteria can go into your body and cause a systemic infection. So oral care is extremely important. One of the other things that can be difficult is making sure that you're getting enough food and fluids. If you've ever had any type of mouth issue, an abscess, a broken tooth, you know how painful eating and drinking can be. So these patients that have issues with their mouth may be at risk for not getting enough nutrition. And we know we need calories to heal. So make sure that that's part of your interventions to make sure that they're getting high quality foods and stuff that they can tolerate. And then the other big thing is just minimizing pain and discomfort. Neither of these require narcotics or overall pain medication, but just using techniques to help with it. Maybe really hot beverages are going to be very painful. Cold beverages might be better, things like that. And people will tell you what works. Any questions on those two? All right. Let's go to the esophagus. Esophagus, okay? So we're going to talk about GERD. You have probably taken care of somebody with GERD. It is an extremely common disorder that affects many, many people. What happens with GERD is the gastric contents go back into the esophagus. The primary cause of GERD is an incompetent lower esophageal sphincter. So that sphincter doesn't close all the way, and those back contents will work its way back up and cause irritation. That backflow can cause a lot of discomfort and a lot of irritation and a bad taste in your mouth. If we don't treat GERD, it can cause esophagitis, which is inflammation of that esophagus. The lower esophageal sphincter is a high pressure area, so it's just above the stomach. The sphincter closes when we're not swallowing, but it relaxes after each swallow to allow the food to enter the stomach. So if there's a lot of intra-abdominal pressure, it's going to keep that esophagus open, and then contents can leak backwards. Other causes of GERD are going to be things like pyloric stenosis, which we see primarily with little kids, hiatal hernias, anything that will increase intragastric pressure or abdominal air pressure like pregnancy, or any type of mobility problems. There is no belching or burping associated with GERD, however. So the symptoms of GERD, that heartburn feeling, sour taste in your mouth, that dyspepsia, coughing, sore throat, difficulty swallowing, chest pain, which is scary because chest pain is a heart attack until proven otherwise. And then my favorite, feeling swallowed food re-enter the mouth. That's regurgitation. So those are the primary symptoms of GERD. Not everybody has all of them, but they are very common. Other things that we can see as a result of GERD are things like dental erosion. That acid can wear away at the enamel of the teeth. It can cause ulcers in the stomach or the esophagus. It can damage your throat, and it can cause cancer, and also can lead to pulmonary issues because of the backflow and aspiration risk. So things that lower LES pressure, so things that will open it up, are things like alcohol, cigarettes, anticholinergic drugs, and calcium channel blockers. Things that will increase the pressure in the abdomen and cause that acid to go backwards are going to be things, again, like pregnancy, obesity, or any type of excessive bending or squatting. So to diagnose GERD, good old EGD, we're going to take a look around with that scope. We're going to give them their conscious sedation, so some Versed and Milk of Amnesia, put the camera down, and we're going to take a look at the esophagus. We do the EGD after of history and physical. They talk about their symptoms, we do an assessment. This is the next step. So again, that EGD is going to let them see the lower esophageal sphincter and the esophageal tissues. Barrett's esophagus is a precursor to esophageal adenocarcinoma. So the mucosal lining of the esophagus gets altered. It's no longer these pretty squamous epithelials. They're now going to be more column lined, and they're going to look like intestines. The lining will be red and not pink, and the patient will have symptoms of GERD. So we diagnose this with a biopsy, and then treatment for Barrett's esophagus is going to be continuous biopsies, proton pump inhibitors, and maybe even some stents or even resection. But again, if we don't treat GERD, that can lead to Barrett's esophagus, which can lead to cancer. So, moral of the story is let's treat the GERD, all right? And your barium swallow, that is your upper GI series. So they're going to have that barium drink with the x-rays under fluoro and watch how things are going down. It's going to be looking for any type of structural abnormalities, any issues with hernias, anything that just doesn't seem right, and they can see exactly how it goes down. So if something's blocking it or causing an issue, they're able to identify it. The medications for this unit are almost all the same. So that's some good news. Also, these are medications that you guys are probably really familiar with already. Your PPIs, your proton pump inhibitors are going to help decrease gastric acid production. And that's going to be your pantoprazole, your Protonix, or your omeprazole. So we want to take those 12 hours apart from vitamins, because that can decrease how well they are working and absorbed. Your antacid, that is going to neutralize acid. We've probably all taken a Tums at some point in our life. Their whole job is to just kind of neutralize it and make you feel better. Histamine 2 receptors, this is your famotidine. This also helps decrease the acid. And then metoclopramide, aka Reglan, helps accelerate gastric emptying, meaning it's going to push things along. The more food that sits in the stomach and the longer it sits in the stomach, the more acid is produced. So something like metoclopramide is going to push it along, so it'll decrease the amount of acid needed and won't sit there and hang out. And then your Carafate will help coat the stomach and just overall make it feel, it's a soothing agent and offers a layer of protection. So these are all meds that you're going to see for multiple disorders. In terms of what we're going to teach our patient, a lot of it is going to come down to diet. We want a low-fat diet. We want to avoid things like caffeine, beer, carbonation, even peppermint. The foods, the caffeine, the tobacco, the milk, the peppermint, they will relax that lower esophageal sphincter. Things like beer and carbonation will increase that abdominal pressure, which will open up that lower esophageal sphincter. If you've ever drinking Sprite or a bubbly water or a Perrier, it makes you burp, right? That's an increase in pressure. So people with GERD, we would want to avoid anything with a lot of bubbles for that reason. We also want to make sure that they're eating 4 to 6 small meals a day. The less you eat, the less acid being produced. So we want to do it in smaller increments. You can eat the same amount, just in smaller times. Lifestyle modifications are going to be important here. We don't lay down for at least 2 hours after eating. If they lay down, that's going to cause that acid to go back up and cause an attack. Weight loss will be important. And then keeping the head of the bed elevated. How can we elevate a head of a bed when a person's at home and doesn't have a hospital bed?
Come up with some pillows.
Okay, pillows.
What about, or sit in a recliner?
definitely. Anything else?
You can put blocks under the head of the bed, the two, whatever, at the head of the bed.
I did that with my son when he was little, just kind of like put him on a little bit of an incline, which can work. With kids, it's harder because they tend to like slide and twist themselves in the bed, and they're never like upright. They're always like in a ball. I don't know, but definitely that. There's wedges you can put underneath the mattress to elevate the mattress, or at least that side of it. So there's definitely things that people can do at home that doesn't require a brand new bed. The other thing that we would want to avoid is things like tight clothing around the abdomen. So no corsets. Anything super tight or constricting will cause that acid to push back up. It's going to find a way to go. We talked about the meds. Oh, sorry. There are surgical procedures that can't be done in extreme cases of GERD, and that is something called a Nissen fundoplication. We'll talk about that more in a little bit, but basically it's going to tighten that lower esophageal sphincter to prevent the backflow of the acid. Left untreated, it can lead to a lot of pain, inflammation. The cells are going to break down because that stomach acid belongs in one place, in the stomach. The stomach can handle it. The esophagus cannot. Or it can lead to, again, that Barrett's esophagus or even aspiration. Any questions on GERD? Feeling pretty good about it? All right. So esophageal varices are the next thing, which are basically, they are dilated submucosal veins in the esophagus. So they're underneath that light layer of skin, and you can, I mean, we all have these veins, but they get engorged and enlarged because of portal hypertension. So the liver is failing. It's increasing all this pressure, and it's causing those veins in the throat to dilate. So portal hypertension has to do with the liver, not with the heart, but with the liver. These are caused by cirrhosis, and they're almost always caused by alcohol. This is a symptom of very bad alcohol abuse. With these, however, we don't have any signs and symptoms that they exist until they rupture. Providers can assume that they're there. Maybe they'll do a scope or something for any number of reasons and find them, but we don't really know that they're there until they rupture. When they rupture, the patient will be vomiting blood and having melena, which is blood in their stools, but it's a dark tarry stool because it works its way all the way down the digestion tract. So it won't be red, it'll be black. They'll also have low blood pressure, high heart rate, which are indicative of hypovolemia, or and they'll have massive blood loss. So patients can die from one of these rupturing. This is why we don't put NG tubes in patients at the bedside, in patients that we are concerned about this. So this patient, you can see they are fat and puffy, sticking all the way out. If you stuck an NG tube in this patient, the likelihood of you rupturing one of these delicate little veins is extremely high, and they will start choking on their own blood. So don't do it. The treatment for varicose veins is going to be IV octreotide. It's a drip that will lower the pressure in the liver and the GI tract, and then Protonix, which we know decreases acid, the amount of acid in the stomach. They will then take these patients in and do either a clip or a band or a coil to stop the bleeding or to remove the varice. And this is a picture of it rupturing, just spurting out its blood everywhere. And this is a band, which is going to kind of pull, kind of kill it, basically cut off the blood flow, and then it just kind of goes away. This is very, very up close. They can still swallow and stuff when these are done, but these, we need to be very, very careful. There is a high risk, again, of rupture and subsequent death with these. Hiatal hernias are our next condition here, and this is going to be when the stomach decides it's going to move into a spot that it's not supposed to. So with a hiatal hernia, we have our diaphragm. Here's your esophagus, here's your diaphragm. Your stomach is below the diaphragm. With a hiatal hernia, that part, the top part of the stomach decided to shift its way out to where it's not supposed to be. With hiatal hernias, we're going to have reflux symptoms, that heartburn, chest pain, dysphagia. But unlike GERD, these patients will also be belching a lot of burps. Okay, this is a common finding with age. It's also common with esophageal cancers or trauma. Obesity and smoking are common risk factors. These patients may also have issues with swallowing. And when they are belching, it's kind of smelly and acidic smelling. To diagnose the hiatal hernia, we can do that barium swallow, the EGD, or we can just do like a CT scan of the chest. Any of these will diagnose that hernia, and then we start them on medications. So the medications that we're going to start, PPIs and antacid. That's it. We want, again, we always want to start low, work our way up, see if medications work. If they don't, then we can look at other options. Typically, patients can take meds and learn to live with this. If it is causing a lot of issues, this is where that Nissen fundiplication comes into place. So they're going to take the top of the stomach, the fundus, and they're basically going to wrap it around the lower esophageal sphincter to tighten it. So that way it'll open and close the way that it's supposed to now. If they do have surgery, we want to, same post-op rules apply. It is laparoscopic, so it's minimally invasive, but we want to avoid heavy lifting. Lifting increases abdominal pressure. If you've ever lifted something up, you're always like, you are bearing down when you're lifting up. That increases pressure. So patients that have this procedure, we would want to avoid that. Also, we need to change the diet and we need to lose weight. We want to decrease that pressure however we can. In terms of what they can eat, we want, if they have surgery, soft foods, no heavy lifting, low fat diet, avoiding things like coffee, peppermint, anything that is going to relax that lower esophageal sphincter and cause contents to go backwards. Again, same rules apply. 4 to 6 small meals, elevate the head of the bed, don't lay flat. Everything for GERD is very similar here to a hernia. So very similar. All right, let's do our first polling question. Okay, so which patient is most likely to experience GERD? So an obese patient with a hiatal hernia. Yes, that's 2 risk factors there, okay? A smoker with a history of COPD. Yes, smoker means they are still smoking, and smoking puts you at risk for GERD, so they're most likely to. An elderly patient with osteoporosis. Not really. Osteoporosis has no bearing on somebody having GERD. 45-year-old alcoholic. Yep, they're drinking, high risk for that. And then a middle-aged adult with a functioning lower esophageal sphincter. I didn't show the results, I'm sorry. We want we want it functioning. So if it's functioning, it means it's doing its job, which means they would not be at risk for having GERD. All right. Next, any questions on anything with the mouth and throat and stomach that we did so far?
So just because they're elderly does not put them at risk. Okay.
No. It's very, very common, but it's not a risk factor. All right, so let's talk about gastritis. So gastritis, at the heart of it, is inflammation of the stomach. The lining of that stomach is mad for some reason. This can happen for a couple different reasons, and there's a couple different types. So non-erosive gastritis is caused by H. pylori. H. pylori can cause ulcers, which is peptic ulcer disease, which we're going to get to in a little bit. Symptoms of H. pylori would be things like upper abdominal pain, feeling full after you eat just a little bit, bloating, loss of appetite, and then some dark stools because potentially bleeding. H. pylori is common in children and primarily in areas with poor sanitation. H. pylori is also spread by contact, so don't think that you're safe. Anybody can get it. How do we test for H. pylori?
Can't you do like a breath test?
Okay, we do the breath test. We breathe into one bag, drink a drink, breathe into the other bag. There we go. How else? Who remembers from last week? We can test their stool. So we can do H. pylori test in the stool. Non-erosive, I'm sorry, erosive gastritis is going to be caused by something else, like NSAIDs. NSAIDs are very harsh on the stomach. Alcohol, very harsh on the stomach. And radiation, well, radiation is hard on everything. Erosive gastritis, however, has an increased risk of stomach cancer. Okay. Acute gastritis comes on quick and is short. This is usually caused by somebody drinking something that they shouldn't. They ingested a toxic chemical. They drank bleach. That can cause acute gastritis. Anything you can think of, or another acid. And then chronic gastritis is going to be related to either an autoimmune disease or H. pylori. So a couple different kinds that we have to think about. Okay, so when we are assessing for gastritis, standard rules apply. Family history. Having a family history of gastritis is a risk factor for somebody else to develop it. If they are on NSAIDs for long periods of time or heavy drinkers, they are at risk for this gastritis. Smoking, immunocompromised. So acute gastritis and chronic gastritis have different symptoms, and they also have some that are the same. So your expected findings are very similar, like they'll cross over. With acute gastritis, we're not eating, we're gonna have pain in your epigastric area, so like right here, vomiting blood, hiccups, black tarry stools, nausea, vomiting. With chronic gastritis, more belching, Not being able to tolerate spicy foods, anything is kind of irritating, nausea, vomiting, sour taste in the mouth. But with chronic gastritis, when you eat, your pain is relieved. With acute, eating causes pain. So there's a difference there. And then hiccups that go on forever. So to diagnose gastritis, we're going to look at the blood work. Okay, we're going to look at a CBC count. Are we bleeding somewhere? H. pylori, because that's a big cause of gastritis. Are we positive? Other ways that we're going to also diagnose is we're going to do an EGD, and we're going to biopsy some of that stomach tissue to see what's going on. And then other things that you're going to do, watch for a GI bleed. We don't want to see a bleed, and we get into the signs and symptoms of that in a little bit. And making sure that patients are educated, what to eat, what to avoid, and then their medications. The gastritis medications are darn near the same as our GERD medications, PPIs, antacids, the Carafate, the mucosal protecting meds. The difference is we added antibiotics. If it is an H. pylori infection, we treat H. pylori with 2 weeks of antibiotics. And then we also have medications like misoprostol to help with protecting the stomach. Misoprostol is a medication that can also induce a miscarriage. So we have to be careful with this medication. So if a woman's having a miscarriage, they can give misoprostol to open up the cervix to help with the passing of the products of conception. So we have to be careful with who's coming in with this medication. Or if a woman is of childbearing age and taking this medication, she needs to be on birth contraceptives, probably multiple forms. So more education, same thing. Avoid the foods, avoid caffeine, help with stress. Gastritis can lead to ulcers. Stress really does cause ulcers. That is not an old wives' tale. And making sure that they are following through with their medications. The big, bad, scary things that can happen with gastritis is bleeding, a GI bleed, dehydration, and then the big one is pernicious anemia. So in pernicious anemia, the stomach no longer secretes the intrinsic factor that is necessary for vitamin B12 absorption. So if that is not being made, the body does not get the B12 that it needs. And gastritis will damage that mucosal lining, which interferes with the body's ability to produce it. So common symptoms of pernicious anemia: pale skin, pale mucous membranes, weakness, fatigue, nausea, vomiting, loss of appetite, just bleh, ickiness. And then the big one is glossitis, which is a swollen, inflamed tongue. That should scream vitamin B12 deficiency. So these patients would need vitamin B12 supplement injections for the rest of their life. Alrighty. Let's go ahead and do another poll question. Okay, so how is pernicious anemia a complication of gastritis? And that is C, the gastritis damages the stomach mucosa, which interferes with the ability to produce the intrinsic factor.
You don't have the results up again.
Sorry, I'm really bad at clicking that button.
Isn't it vitamin, is it vitamin D that is absorbed through the intestine or has something to do with that? This doesn't affect that, just the
No.
vitamin B.
Yeah, so vitamin B12 is different. Vitamin D is absorbed because of calcium. Like they work together to synthesize that vitamin D. It activates it, the calcium activates it. Vitamin B12, again, would be because of what's going on in the stomach.
Hmm.
All right. Well, we got that through that pretty quickly. Let's go ahead here and this is where I break. So we are at 10:43. Let's you can take a little bit of a longer one. Let's come back at 11.
You should have seen by the look in my eyes, baby. There was something missing. You should have known by the tone of my voice, maybe, but you didn't listen. You played dead, but you never did. Instead, you lay still in the grass, all caught up in the time, my love, when you counted. But I'm singing like a bird out in the I couldn't whisper when you needed it shouted. But I'm singing like a bird out in the birds on the boat, never would fall. Like a crane at the final breath that is drawn.
Cardinal lost.
Love, when I'm reborn, is a train to your side in glorious thorn. Had no idea, my friend, I was stranded. All of that goodness is gone, but you know. Then when I met you, my virtues uncounted. All of my goodness is gone, but you know. Dragging along, following you forward. Home like the bell of some prelude war. Remember that love and every boy is a train to your side in glorious thorn. Fled to the city, so much discounted. When I'm flying like a bird to you now. Back to the hedgerows where bodies are mounted. I'm flying like a bird to you now. I was last born, last transformed. But you're grounded and giving and darkened and sworn. Remember that love when every boy change from this burnout scene. Another time, another town, another everything. But it's always back to you. Stumble around in the night, in the pouring rain. In the past, and thought there's more I need. It's always back to you. Well, I'm good without you. Yeah, I'm good without you. Yeah, yeah, yeah.
All right, how are we doing? Ooh, hi, okay. All right. All righty, so the next thing that we're gonna get into is gonna be peptic ulcer disease. So peptic ulcer disease is basically an ulcer. It's an erosion of the mucosal lining that can happen in the stomach, the esophagus, or the duodenum. These are very common. So basically acid has worn away, or in conjunction to other things that you've taken in your body, like drugs or stress, have worn away that lining. Most ulcers are duodenal, but they can occur in the lower esophagus, the stomach, and anywhere, even the jejunum. The two major causes of ulcers are going to be H. pylori and NSAID usage. So what happens is it starts to wear away, and eventually it can get so bad that it creates a hole in wherever its weakness is, and then that contents can start leaking into the peritoneal cavity. So that's obviously something we don't want to happen. So your causes, again, H. pylori and NSAID use are your two big ones. Not treating GERD can cause peptic ulcer disease. Stress. We've all heard that joke. That job's going to give you an ulcer. It absolutely can. And then other conditions like COPD, cirrhosis, or even kidney disease can cause this. We have very similar expected findings to GERD with the dyspepsia and then some mid-epigastric pain. But with peptic ulcer disease, we can also have bleeding. So we're going to have bloody vomit and black tarry stools, the melena. With gastric ulcers, pain is most commonly going to occur 30 to 60 minutes after eating. With duodenal ulcers, because it's further down, we don't have pain until like hour and a half up to 3 hours. It'll wake them up in the middle of the night is a very common thing, that pain. But by eating more, it actually relieves the pain, or they can take an antacid. Moral of the story is we want to get this treated because we don't want these ulcers to hemorrhage, to be bleeding everywhere. So to test for peptic ulcer disease, we're going to do an H. pylori test because it's a big cause of it. We're also going to check an H&H. Are we bleeding? That hemoglobin and hematocrit is going to tell us if we have bleeding going on. And we're also going to check that fecal occult blood test. Procedure-wise, we'll do an EGD. We'll do take the scope, take a look around and see what's going on. Get measurements of the size of the ulcer and determine our next course of action. So caring for somebody with peptic ulcer disease, we really just want to watch their labs, watch their vital signs, and we're going to give medications. And these are the same medications that we've had with GERD, PPIs, antacids. The only difference are the antibiotics, especially if it's caused by H. pylori. Okay. With gastric ulcers, you tend to have weight loss and some vomiting, and again, pain when you eat. With duodenal ulcers, we don't have weight loss. The normal body. Pain starts 2 to 3 hours after eating, and food is actually going to help decrease the pain. So just like with GERD, reduce stress, no alcohol, no smoking. All of that will aggravate the ulcer. So treatment is going to be medications, first and foremost, lifestyle modifications. If that doesn't work, we can look at surgery. Surgery only happens after 3 to 4 months of therapy. So they have to be on meds for 12 to 16 weeks before they're going to consider doing a surgery, unless there is a life-threatening hemorrhage, and we need to do that. So surgery is only indicated if we fail meds, if they're worried about hemorrhage, or even maybe like cancer. Okay. So the different kinds of surgeries that they can do is a gastrectomy. That's going to remove part of the stomach, and the part that they're removing has the hormonal stimulus that releases the parietal cells, so that portion would be removed. They can do a bypass of the stomach, where they're going to remove part of that lower layer and then bypass it right to the duodenum. So it's a very small area now. So it's kind of like a gastric bypass, but not. A vagotomy can also be done, where they're going to cut part of the vagus nerve, which will decrease the hydrochloric acid production. And then a pyloroplasty will basically create a bigger lumen to help with gastric emptying. So it's going to get food out of that stomach quicker, so it's not sitting in there and where acid is being produced over and over again. If they have surgery, guys, your post-op care does not really differ. It doesn't matter if they had a stomach surgery or a foot surgery. Our goals: prevent infection, prevent clots, prevent those post-op complications. So we're going to do dressing changes. Every surgery does have something, though, that we're going to specifically do. If they have a gastric surgery, they're going to have an NG tube. We expect that drainage to be bloody for the first day or two. However, we do not do anything with the NG tube unless it is specifically ordered by their surgeon. I don't care what doctor says anything. If it is not their surgeon, it is not happening. So their surgeon could say, go ahead and irrigate this. If it's their, another doctor, let's run that by the surgeon. They make the call, okay? So we don't adjust it, we don't tinker with it, we don't do anything unless the surgeon says so. After surgery too, we're gonna monitor for bowel sounds and advance that diet as tolerated. They're gonna start low and slow, clear liquids, work their way up and that sort of thing. The big bad scary things is going to be hemorrhage. If the ulcer perforates through the lining completely and we're bleeding, this patient needs emergency surgery. Other complications: pernicious anemia. That intrinsic factor is gone again, and that can result, they're going to need those monthly IM B12 injections because they can't absorb it otherwise. Dumping syndrome is another complication after surgery or peptic ulcer disease. So they're going to eat, and all of a sudden they feel like crap when they're eating. They get real bloated, real icky, going to have weakness and real sweaty, and then massive diarrhea. So dumping syndrome, their body is literally dumping everything that comes out of it. And it has to do with fluid shifting. And your body's like, nope, I'm out. And it just dumps it out because of rapid gastric emptying. So that can also happen with PUD. If there is an issue with the pyloric obstruction, they can put in an NG tube as well. So lots of big things that can happen with peptic ulcer disease. Some can definitely be an emergency.
Is dumping syndrome something you would see later, or is that like it can happen alone? It's not like an early or late sign, it can just happen?
Typically, so we see dumping syndrome usually with tube feedings, sometimes like with ulcers when they're really bad, or with after surgeries, after they have like gastric bypass and things like that. That's a major complication. So fluid gets pulled into an area and your body is just like, nope, and it just expels it.
So this isn't like, oh, you ate something and it just runs right through you.
That's basically what's going to happen, but it has to do with the osmotic shift in the fluids inside the gastric contents
Okay.
and your intestines. So the education, same thing, avoiding these foods. So no coffee, no tea, no carbonation, very similar to what we've seen before. The big difference with peptic ulcer disease, though, is that we want to avoid extremes in temperatures. And I'm not talking about like Hawaii versus Alaska, the food and drink that you're consuming. Cold hurts, really cold stuff hurts, and hot can cause bleeding. So if we want more things more like room temperature. No NSAIDs, because if we have an ulcer, the last thing we want to do is aggravate it more, right? Stress techniques, relaxation, therapeutic communication, distraction, anything to help them deal with their stress and anxiety, not smoking. It is important that we monitor for bleeding, okay? And then reiterate that diet changes are key with this. If they're taking antibiotics, take the full course. That does not change. I know you're going to feel better. Don't stop. If you start having massive diarrhea, report that. That teaching does not change either. What is bismuth salicylate? Pepto-Bismol. Most people don't know this, but you guys hopefully do because you're nursing students, but Pepto-Bismol has aspirin in it. If we are bleeding, we want to avoid aspirin. So patients with peptic ulcer disease should avoid Pepto. Yeah, it'd feel good, but that aspirin can cause more bleeding. So typically we'd want to do something more like a Carafate if we need that smooth relief, if that makes sense. But yeah, every Joe Schmo doesn't know that there's aspirin in it. That's why kids shouldn't take it either. But we don't like kids in this class. Tough crowd today. You guys are mad at me.
Job gonna be in person or is it gonna be on Zoom?
It's in person. I have to people again and wear clothes that match.
That'll be a nice change though.
I don't know. I don't know if I'm ready to people again. Although I have to wear a mask so I can still hide part of my face. Because if my mouth doesn't say it, my face sure does.
Yeah, I got that same problem.
Thanks, Anna. All right, so when is it appropriate for somebody to go have surgery with peptic ulcer disease? And that's going to be there is a life-threatening hemorrhage of the stomach. Yes, we would want it before it perforates. However, we have to do things beforehand, and there's not a good time frame. So B is the better option here. And 1 week is not nearly enough time to take meds. Remember, we need 3 to 4 months for that. I did it again, for that to be what we want to do. My bad. All right, so this chart is very helpful for comparing the diseases. So if you are a printer, this can help you with your studying because there are certain symptoms that are very similar, diseases that are very similar. But look at here, PPI and antacids, PPI and antacids, PPI and antacids, PPI and antacids. Yay! Like a big group of these have the same meds. Woohoo! But there are some dietary differences, okay? So with that being said, I'm going to launch the next poll question to kind of help you guys out here. Little cheat sheet. Does anybody do the Wordle? Did you do it today, Samantha?
I haven't. I try to do it when I sit in the sauna at the gym, but is it hard?
It made me so angry today.
No.
They've been on a little bit of a roll with not being very nice.
Yes, lately I'm like, okay, cool. Don't even know what that word is, but all right.
Yeah, I was pretty PO today. I was doing that on break, and I'm like, are you kidding me?
I'll do it on break and let you know.
I feel like a lot of streaks are going to be broken today. All right, so which erosive diseases does the nurse need to include to avoid caffeine? And that is going to be GERD, right? No. I don't even have my answers up right. Peptic ulcer disease, gastritis, and GERD, right? Yes, okay. Hiatal hernia, technically we don't need to avoid caffeine with. That's tricky, and that's why I left the chart up for you guys. But for the most part, we avoid it in general. Esophageal varices and candidiasis actually don't have any dietary restrictions, really. It's gonna be about comfort. So, did it again, I didn't share, I'm sorry. I don't like to share. So GERD, gastritis, and peptic ulcer disease. Alrighty. So now we're going to get into the non-inflammatory bowel disorders. I feel like these kind of go pretty well because we've seen these, we've had these. It's a lot more familiar. So first and foremost, let's talk about diarrhea. So diarrhea is going to be more than 3 bowel movements a day with increased liquidity, meaning it's just coming right out of you. There's no solid pieces in this. And if it does, it's like little floaters, okay? So hopefully you guys are familiar with that Bristol stool chart. Type 1 is going to be your hard pebbles that are very hard to pass. Type 2 is going to be a little bit more formed, but it's going to be lumpy and painful. 3, I mean, they ruin food for you, really, like a sausage, but with cracks. We want it to be at a 4. A 4 is ideal, okay? Smooth and soft, easy to pass, doesn't require straining. So with diarrhea, we have causes, and usually if we can treat the cause, the diarrhea goes away. It could be viral. We came in contact with something, we just feel icky. Okay, this is the end result. Medications or illegal drugs can also cause this. It can be a symptom of another disease, or it could just be a result of having Taco Bell for dinner. So something that you ate can cause diarrhea. In terms of complications, the big things that we have to look out for is just dehydration. How would I assess someone for dehydration? What am I looking for?
And they have like sunken eyes, whatever, and their oral mucosa looks not pink.
Okay. Yeah, we have tenting in the chat. So if we pinch them, the skin stays upright. Where is the best place to assess for tenting?
The clavicle.
Up the clavicle, the sternum. We do the back of the hand because it's the easiest to get at. You know, if they're wearing a hospital gown, you kind of gotta stick your hand down their shirt, and they might not like that as much, but definitely we want to look for that skin. Low blood pressure, high heart rate, dry skin, kind of like how you feel after you work out on a really hot day. You feel kind of blah. Yes, you did a workout, high five, that's awesome, but you need to replenish those electrolytes in the fluid. And when you do, then you feel better. So we want to make sure that we're assessing people that are having diarrhea for that complication. The other big thing is just dermatitis in general. You've all had diarrhea. It hurts coming out sometimes. It can burn and it's not pleasant. So the frequent cleaning with toilet paper can cause irritation to the perineal area. So again, things like warm wipes or something soft will be much better for the skin in that area. And educate them, no matter what the package says, a flushable wipe is not flushable. Okay, it will ruin your plumbing no matter what. It's a lie, false advertising. So in terms of treatment, if someone's having diarrhea, one of the first things that we're going to do is have them tested for C. diff. If they have C. diff, then we're going to treat them for C. diff with the antibiotics and have them in precautions. If it comes back negative, then we have other options too. Hydration, no matter what, but also loperamide. Loperamide is Imodium. It's an over-the-counter anti-diarrheal medication. So you take 2 at the onset of your diarrhea. The next time you have another loose stool, you can take another one up to like 5 times a day or something like that. Diphenxylate with atropine, Lamodal, is also an anti-diarrheal medication, but it's a prescription one. So those are the differences. Both work very, very well to help to harden up the stool. Comfort is going to be important here. We have to also watch that they're eating, and if they are eating more like bland foods, things like that, because most people are afraid to eat because they don't want it to come back out, but we still need to get some nutrition as best we can. All right, fecal incontinence. So fecal incontinence is one of those things that is common in adults over 65, but it's not an expected finding. It's not normal. But what happens is that the person is passing stool without knowing it, or they can't stop it for more than 3 months. So some things that can cause this are muscle damage because of childbirth. Thanks, kids. Nerve damage due to diabetes or a stroke, a spinal cord injury, if they've had a back injury, anything that can damage the nerves that your body says, hey, I have to go. I don't know you all personally, but I'm going to go out on a limb that if we have to poop, we can hold it until we get there. These patients can't. And it'll just kind of come out of them. There's nothing we can do, but they can do about it. This can, again, also be caused due to weakness in that anal area. Maybe they underwent some trauma, had stuff stuck in there that they shouldn't have. It can decrease the rectal tone and cause things to slip right on out. The thing is that there's not physical complications with fecal incontinence aside from a decreased quality of life. Most of us would not want to have to wear a diaper or constantly be in fear of pooping our pants. So the biggest issue is more of a emotional one. If they are suffering from fecal incontinence, we want to treat the cause as best we can, get things under control. Maybe they need some kind of surgery or procedure or something to help strengthen rectal tone or help with muscles. If they can, they might not be able to. Loperamide, that anti-diarrheal, can help firm up stool so that way it's more difficult to pass versus if it's liquid, it can just slide right through. Also maintaining that skin integrity. We don't want any issues with the skin forming because they're passing that stool, and that stool is very irritating to the skin. And one that's not on here that I feel like should go without saying, but whatever it is just maintain dignity. You know, most people don't want to poop their pants. And if they're younger too, it can be a lot more difficult for people to handle. So treat them with dignity and respect. All righty. On the flip side, we have constipation. So constipation is less than 3 bowel movements a week, and they will be either type 1 or type 2 on that Bristol scale. So really hard to pass, rock hard stools. Causes of constipation are going to be usually due to medications or your diet. If we don't have a good diet, you are at high risk for developing this. We want plenty of high fiber foods. and fluids. What are some examples of high fiber foods?
Fruits.
Whole
Fruit.
grains.
Whole grains.
Legumes like beans.
Beans, a magical fruit. So yeah, fruits, vegetables, beans, whole grains, bran. Raisin Bran is a great cereal because it's full of the stuff that you need to help keep you regular. We want to avoid processed foods. Dairy can be very constipating for people, and so can a lot of meat products. So we want to limit those. Also, drinking plenty of fluids. We say fluids, make sure that your patients understand that that's water, because your fluids and my fluids could be completely different. I had my 40-ounce beer yesterday, I'm good. Okay, that's not the same thing. And I've had people say that to me, so we have to specify. Also, stay active. We want you to keep moving. We want peristalsis to happen. If we don't treat constipation, we can end up with syncope, vasovagal response. You bear down. When you bear down, you increase that intrathoracic pressure in your abdomen. By increasing that pressure, you're going to smush your blood vessels, which is going to decrease blood flow. And then your patient passes out. That's why people pass out on the toilet when they're constipated, because they're straining so hard that their blood vessels are not going to get enough blood through them.
Is that the same thing that causes the weightlifters to pass out like you see on YouTube?
Yes, because it's the same thing. When you bend over to pick something up and you're straining, you increase that pressure. Same thing. And sometimes people will fart. You know, they'll be at the gym and they're pushing. It forces its way out. You know, same thing with yoga. You've probably all been at the gym where something like that happens. But yeah, absolutely. Constant straining can also cause hemorrhoids, which we talk about in a little bit. And then some of the other things that can happen are megacolon and toxic megacolon. So if your intestines are full of stool, they're going to dilate and get irritated. And with toxic megacolon, it can get infected and it can lead to death. So not pooping could cause you to die. We want to push things along. So fluid, good foods. In addition, we have laxatives and we have enemas and things like that to help. Everything acts in its own different way. So something like Metamucil is a bulk forming laxative. You've probably seen people mix that in with their juice in nursing homes or things like that. It's a lot of fiber. It's to help progress and move things along, create things, pull fluid and go. Milk of magnesia is another, it's a gross tasting drink, but it helps change the stool consistency. It kind of draws in some water and lets things move. Mineral oil, it's like a lubricant, helps slide it on out. Bisacodyl or senna are your laxatives, your stimulant laxatives. They are going to make the colon mad. They're going to be like, which will create peristalsis and help move things along. Docusate is going to help hydrate the stool. It's not going to have a laxative effect, but it's going to help you make stool soft. It's a stool softener. And then your osmotic agents, this is your Miralax or your Go Lightly, that is just going to induce diarrhea. Pull fluid in and push it on out. The older you are, the more concerned you get about your bowel movements, and you will tell anyone and everyone all about them. That is very true. So diet, exercise, stress prevention, and also one of the big things, you see this more with kids than you do adults, but ignoring the urge to defecate. Kids will be so active and playing and they don't want to stop and they have to go. If you hold it in, you're more likely to become constipated. So if you have to go, go. Everybody poops, it's okay. and maybe even start working on like a toileting schedule. For patients that have spinal cord injuries, they do digital stimulation like clockwork to get them to go at the same time every day. So poop schedules are very real. Any questions on constipation, diarrhea? Pretty straightforward. All right, the hemorrhoids. So hemorrhoids are basically varicose veins in your butt. They can either be internal or external. They're most commonly caused by straining because of a bowel movement or being pregnant. Those are the two big ones. It's not uncommon for in delivery, you're pushing, and then boom, these little hemorrhoids decided to pop their way out in addition to your baby. But sitting on the toilet for long periods of time, because you're probably straining, can also lead to them chronic diarrhea, chronic constipation, being obese, low fiber diet, anal trauma can all cause the hemorrhoids to occur. Heavy lifting, straining, can also lead to the hemorrhoids being produced, just like, you know, lifting things. I pick things up and I put them down. Yeah. Christina asked, well, we need to know what each med is doing for constipation. I would definitely say like know a brief summary. Like the lubricants are going to help move things along. Colace is a stool softener. It softens the stool. Real brief. With hemorrhoids, they typically present themselves itching and some pain. They make topical ointments that you can put on there. But its hallmark giveaway is that there'll be this bright red streak of blood when they go to the bathroom. So there'll be a piece of poop and there'll be a streak of blood along the top of it, because as it's passing out that anal canal, it kind of just drags along the hemorrhoid. So we want to make sure that we are really taking care of personal hygiene, cleansing that area as much as possible, not straining when we're going to the bathroom. So we want to prevent constipation. High residue diets to have smaller, fewer bowel movements, so that way it's not like a big one at once. High fiber foods, plenty of fluids, and not sitting for long periods of time. In severe cases, they can do hemorrhoidectomies where they can remove the hemorrhoids, but it has to be something that maybe they're worried about infection or quality of life, or there's multiple. One little hemorrhoid is not going to be the end of the world. That they need more, or it has to cause a problem for the surgery to occur. With hemorrhoids, we don't do fecal occult blood tests because it's going to be positive. We know it. If we're worried about a GI bleed, we need to do further testing. All right. Let's talk about hernias. So hernias is when we have an organ pushing through a weak spot in your muscle or your tissue, usually in the abdominal cavity. Very common injury. ATI has really great images of both, so take a look at those, or all the different kinds. They are named based off of where they are located. An umbilical hernia, right at your belly button. Incisional, if you had surgery, a little, it's a weak area because we cut through that tissue, little hernias can occur. Inguinal are going to be more in your groin. So inguinal hernias happen when part of your intestines leak through that intestinal wall and push their way down. And we typically see issues in the groin or even swelling in the scrotum. Ideally, they want to just push the hernia back in where it came from. But if that doesn't work, then they may need surgery. So being a male and being older are risk factors for hernia. Bodybuilders, anybody that does heavy lifting, movers are known for getting hernias because of improper lifting techniques and the straining that comes along with it. So again, we're going to see a little bump, maybe a big one. I've seen some that are like, woo, size of my head, like this big in their abdomen. And if they don't hurt, they typically don't do too much. Maybe they'll put a belt on them to kind of smush it back in. But if they are worried about bowel obstructions occurring or anything like that, then they can do surgery. So they'll put a little piece of mesh over the tissue to kind of act as like a cage, like you may not pass, and it kind of reinforces that tissue wall. If they do have surgery, we want to avoid anything that isn't going to increase that intra-abdominal pressure. So no straining, no heavy lifting, no tight clothing, no gassy foods, and making sure that they're taking stool softeners so they're not straining. Not necessarily laxatives, just easy to pass because we don't want to bear down. Okay. Chat. I just wanted to, oh, yeah. And as long as it's not causing you any issues, they're probably just going to let it be for a while. Would be my guess. Oh my gosh. I have a huge bump. I got my tetanus shot yesterday and I have a huge bump in my arm and I just felt it and it hurts. That's not good. She was new too. She's like, are you sure you want me to do it? And I said, I'd be a pretty crappy teacher if I didn't let you try on me. And I think she didn't do it right. That's what I get. Ooh. Sorry, I hit play. All right, so over-the-counter med for constipation. And that is going to be, haha, I hit it this time, laxatives. Laxatives are used for constipation over the counter. Loperamide is over the counter, but that is for diarrhea, not constipation. And Lomotil is prescription and also for diarrhea. All right. So the next part we're going to talk about is going to be irritable bowel syndrome. So IBS is basically changes in bowel habits. And this is over an extended period of time. This is not like, oh yeah, one day I was constipated once, like a week ago, so I have irritable bowel syndrome. This is ongoing for significant amounts of time. So with IBS, it can either be constipation or diarrhea, or it can alternate. We consider IBS a brain-gut disorder. We don't know the pathophys, don't ask me, because we don't understand it yet. It's possibly some environmental issues, stress, your own body, a combination of all those. We truly don't understand what happens. What we do know is that irritable bowel syndrome typically affects women more. If you eat a lot of fatty foods, that can be an issue, or a lot of caffeine or alcohol. That being said, it affects a significant amount of people, and it's becoming more and more common. So the best way to understand irritable bowel syndrome is that it takes a long, several months to diagnose this because it's ebb and flow, back and forth. We have to rule out other lower GI disorders before we get to the diagnosis of IBS. So we need a very careful history and thorough examinations. The best way to look at this though is with diarrhea. If they have IBS diarrhea, well, what do we have with that? Typically, we're going to have hyperactive bowel sounds, icky stools, just overall feeling of ick. With constipation, probably more distension, belching. You go to the bathroom, but you still don't feel like you got it all. So looking at the expected findings, just think about diarrhea, think about constipation and what you expect with either one of these. When they do diagnose irritable bowel syndrome, they have to have recurrent abdominal pain for at least 3 days a month. And then they also have to have 2 or more of the other characteristics. So either their pain improves with a bowel movement, or pain begins when you change how often you're going, or there's a change in the appearance. So they need 2 or more of those 3 things, plus the pain several days a month. So it takes a while to figure out exactly what is going on here. So IBS is kind of like a blanket statement. We don't know a ton about it, but we're going to treat it as best we can, how we would treat constipation and diarrhea. So with diarrheals, antidiarrheals are going to be helpful here. Constipation, laxatives, increasing your fiber, increasing your fluid, and then avoiding things that are going to be triggering, like spicy foods. Your fake sugars, like your, what's that called? Sucralose and things like that, that can aggravate a flare-up. Fruits, vegetables, fiber will be very helpful here. Avoid drinking, avoid fatty foods, and small frequent meals are going to be the most helpful here. 2 to 3 liters of water a day. Very rarely are these patients hospitalized, so patient education is going to be extremely important here. And they're going to have to figure out what foods and what routines work best for them to control the disease, because there's not a ton of therapeutic things that we can do for them. All right, let's talk bowel obstructions, shall we? So we can have an obstruction in the small bowel or the large bowel. Small bowel obstructions, SBOs, typically will present themselves with abdominal pain, and then my favorite, projectile vomiting of fecal matter. They are vomiting stool at you. Small intestines are right after the stomach. So if the obstruction is in that small intestine, nothing can get past it. So all that stuff has to go somewhere, and it's going to go right back out the way that it came. So that is a dead giveaway that it is a small bowel obstruction. If we were to do any type of ABGs, metabolic alkalosis would be going on, and their fluid and electrolytes are going to be way off, primarily because we're puking fecal matter. The higher the obstruction, the earlier and more severe the vomiting is. So if it's a large bowel obstruction, we typically don't have vomiting. There's a lot more room to work with. But anywhere in the small intestines, the closer it is to the stomach, the closer you're going to start vomiting. Large bowel obstructions will have like some intermittent cramping. They're actually going to be acidotic, and then they may or may not have either diarrhea because it's working around the impaction, or they are going to have ribbon-like stools. So the feces is going to try to work its way through, and it looks like a curling ribbon, you know, like you do for Christmas when you curl it and make it all pretty. It'll have that kind of appearance, real thin, because it's trying to work its way out from what's going on. Regardless of which kind of obstruction they have, they're going to have obstipation, which is trouble pooping. If they have a small bowel obstruction, there's really nothing to pass. And if there's a large bowel obstruction, they can't get it out because something's blocking it. They're going to be distended, whether it's because of gas, fecal matter, stool, whatever. And then they have the Borborygini sound, so that rumbling and grumbling that you can hear sometimes without a stethoscope. And then below the obstruction, it's going to be hypoactive because there's not a whole lot going on because the obstruction's blocking everything from moving through. And typically they're pretty tender to the touch. Bowel obstructions can be either mechanical or non-mechanical. So non-mechanical could be like a twisting of something. That can be an obstruction. A mechanical is usually caused by a foreign object or a block of stool or a block of hair, whatever. But there's two different kinds there. Sorry, I lost my thing. So to diagnose a bowel obstruction, we do imaging. We take a look at things. We're also going to take a look at our labs. So these patients are typically dehydrated. Your H&H is going to go up. There's less fluid to dilate the blood. The BUN and creatinine will go up because it's hard on the kidneys, not having enough fluid. Our electrolytes are going to be off, usually due to vomiting. And then our ABGs we're going to do, and that helps dictate if it's going to be alkalotic or acidotic. Abdominal CT will help diagnose. KUBs are quick, dirty, and to the point. A KUB is a kidney, ureter, bladder. This is an example of a KUB. What do you see here? I know you're not radiologists, but what do you see?
Aren't all those little black spots the stool that are blocked up?
That is stool. This person is FOS. They are full of stool. And you can just see it all the way through the large intestine. Right down here, close to that anal canal. Do you see that big globule? This big guy? That's an impaction. That's a piece of stool. That is preventing everything else from getting out. You know how we remove that? Digital stimulation. You send your least favorite resident in to go take care of that, and they have to manually remove the impaction. So that is what somebody who is full of stool is looking like. So the KUB we get right away. CT takes a little bit longer. Both have their merits. If there is a bowel obstruction, small bowel obstructions, we usually treat first with an NG tube. We're going to decompress. We're going to pull out all that stuff and in hopes pull out the obstruction. If it's a large bowel obstruction, there's not a ton that we can do aside from removing the obstruction any way we can. If it's twisted, they can do a colonoscopy and they can take the camera and the camera can kind of untwist it and then we're good to go. But if there's a big blockage, we may have to do things to help facilitate and pull them around. Worst case scenario, they may have to do surgery to remove the obstruction. And sometimes these patients will end up with either a temporary or permanent colostomy if they can't get it out, if they're worried about how things are going to go. And then rectal tubes can also be used to help pull out drainage, but they typically, we need diarrhea for rectal tubes to collect anything. So it truly depends on the type of obstruction that's going on. So if we have that mechanical bowel obstruction, NPO, we want to give them medications. They are typically going to have an NG tube as well. And then we have to prepare them for surgery if they need to remove that big obstruction, whether it's a twisting or something like that. Non-mechanical also, NPO, watching our bowel sounds, well, listening to our bowel sounds, IV fluids, and managing pain for both. We want ambulation and activity to go on because we want to increase normal bowel functions. We want to increase peristalsis. If they have NG tubes, mouth, nose care, eyes and nose. If they are draining stuff out of that NG tube, which they probably are, we want to talk about how much and what color it is. We have to be looking at that drainage. We also want them to be in a Fowler's position to help them breathe better. If their belly's all distended, laying them flat is not going to help them breathe well. But if they're sitting more upright, it's going to be maximum lung expansion, and they're not going to have to fight against their abdomen that's full of stuff right now. Next poll question. All right. So dehydrated due to projectile vomiting of fecal matter, metabolic acidosis, alkalosis. What are we thinking is going on? That is a small bowel obstruction. If they are puking up poop, small bowel obstruction. Alrighty. Okay, so we are at 11:52. Let's go ahead and take our second break, 11:53, and come back at 12:05. I had to think about that for a second. I'm good at math.
Could you whisper in my ear the things you want to feel? I give you everything to feel it coming. Do you wake up on the throne and wonder where you are? Looking for your thoughts. I wanna wake up where you are. I won't say anything at all, so I can just slide. Don't you love the life you kill? Faces on the phone, the father hit the wall. Your mother's owned you. Don't suppose I'll ever know. So needs to be a man. Second life has changed. Live around here. I wanna wake up where you are. I won't say anything at all. So I can just slide. And I'll do anything you ever do to be complete. Little pieces of nothing but a fall. Put your arms around me. What you feel is what you are, beautiful. Wanted married, go away. I'll do anything you ever dream to be complete. Little pieces of nothing that fall. Put your arms around me. What you feel is what you are, beautiful. Wanted married, go away. I wanna wake up where you are. Can I have anything you ever dreamed to be complete? Can I have nothing that's all? Can I have anything you ever dreamed to be complete? Can I have nothing that's all? All night. I'll just lie to my room. Just lie to my I've been driving for an hour, just talking to me. You say I've been driving crazy and it's keeping you away. Just give me one good reason, tell me why I should stay.
All right. Home stretch here, guys. Bring it on back. So all the previous diseases that we were talking about were non-inflammatory. Now we're going to talk about the inflammatory, which also go by the initials of IBD, because why not be confusing? So with inflammatory bowel disease, we have acute diseases and we have chronic. Your acute are going to be things like appendicitis, peritonitis, or gastroenteritis. And then your chronic are going to be things like UC, Crohn's, and diverticulitis. So kick off with the easy one, appendicitis. This is caused by an appendix obstruction, usually hard stool. It is the most common surgical emergency of the abdomen. So that obstruction of the appendix happens by a fecal mass or a viral infection. If we don't treat it, it can result in perforation. Appendicitis occurs more commonly in men, usually in their 20s and 30s, and will present itself with like fever, right lower quadrant stabbing, abdominal pain. So if we are concerned about appendicitis, we do an abdominal ultrasound. We take a look at that appendix and we see what's going on. The appendix is a very tiny, useless little organ. I always say something's as useless as an appendix because it does nothing. We don't use it anymore. I think it had a function back in the days of cavemen where it like helped with processing like sticks or something. I don't know. But basically this little thing gets inflamed, infected, and then if it bursts, all the fecal content can leak into the peritoneal cavity, which can cause peritonitis. So really all it does is cause issues. So we're going to do blood work. We're going to do an ultrasound. If it is confirmed to be appendicitis because it measures so big, they'll start them on antibiotics and prepare for surgery. They'll have an appendectomy, which can be done laparoscopically or open, but typically they recover very quickly with very few complications. Peritonitis then is inflammation of the peritoneum. That's the lining in the abdominal cavity. So this can be either localized, like an abscess, or generalized, but it will present itself with severe diffuse abdominal pain. That rigid board-like abdomen, weakness, pallor, sweating, cold skin. Another common thing for peritonitis, cause of peritonitis, besides a ruptured appendix, when an ulcer perforates, or which when you guys get to your renal unit, peritoneal dialysis, a little catheter is inserted into the peritoneum and it exchanges fluids. If there's an infection there, that can lead to peritonitis. This is a life-threatening infection that is not pleasant for the patient, and we need to treat it quickly. And then gastroenteritis. It's technically an inflammatory disorder, but this is pretty self-limiting. This is diarrhea, nausea, vomiting, abdominal pain. This is thing like traveler's diarrhea, like you drink the water in Mexico, what happens to you then? This is gastroenteritis. Food poisoning. The treatment is supportive. Flush things out, fluids, typically not life-threatening. The only time that this is really an issue is if the person is elderly or maybe a little debilitated, and that's due to dehydration or electrolyte loss. Any questions on the three of these? Pretty straightforward, I think. We're gonna get into the big ones. So your chronic inflammatory disease are either ulcerative colitis, Crohn's, or diverticulitis. So UC is going to be recurrent attacks of bloody diarrhea with pus and mucus, abdominal pain, weight loss. These patients also have an increased risk for colorectal cancer. They think that it's an abnormal immune response in the GI tract. Crohn's disease is more of a regional inflammation of any part of the GI tract. Crohn's we see more in the colon. Crohn's we can see anywhere. With Crohn's disease, you're going to see, if they do a scope, a colonoscopy, what they call cobblestoning. So what happens is the cells change inside the intestine, and it looks like one of those old brick roads from back in the day that you might have seen like in amusement parks or something like that inside the intestinal wall. A normal colon doesn't have that. There'll also be diarrhea, fat, and right lower quadrant pain. With UC, we have ulcers forming. So there'll be a lot more bleeding, inflammation, very red, painful condition. And then diverticulitis. So diverticula are little herniations that form off of the large intestine. Think of them kind of like little fingers or little balloons that decide to just form. So those are called diverticula. The fact that they're there, that they exist, that disease is called diverticulosis. So it means that the little guys are there, that the diverticula are there. When they become infected or inflamed, that is when we have diverticulitis. So the diverticulosis means that they're there. The diverticulitis, it's an itis, so it's an inflammation or an infection of those little pouches. So diverticulitis can cause fatal obstructions, infection, or hemorrhage because of undigested food mixed with bacteria. These patients will typically have like abdominal pain, nausea, and gas. So all of these are lifelong disorders that can wreak havoc on a patient's lives. Although if I had to have any of them, I think I'd want diverticulitis. That's just me though. So the expected findings. With ulcerative colitis, we typically have left lower quadrant pain and cramping, diarrhea 15 to 20 times a day. That's a lot, with blood, mucus, and pus in their stools. And they're also prone to rectal bleeding. With Crohn's, it's going to be more right lower quadrant abdominal pain. They say diarrhea up to 5 times a day. It could be more depending on the patient, but there's not blood present. It will have some mucus or pus or even some fat in the stool. Both of them, fever, frequent stools, weight loss, not wanting to eat, abdominal pain and distension. And then both of these, they'll go through periods where they're completely fine, they're in remission, and then it'll flare up and hit them. So it's just going to be, it's a lifelong battle of flare-ups. Diverticulitis will have more left lower quadrant pain, fever, chills, weakness, some diarrhea, but you don't see the changes in the stools and the frequency of them. So I guess that's why I'd say I'd want that one if I had any of them. In terms of diagnosis, we diagnose all these with really good H&Ps, but also with imaging. So colonoscopies and lower GI studies, which require a bowel prep, will help us diagnose all three of these. MRI and abdominal ultrasound can be used if we're just worried about Crohn's or diverticulitis. But your colonoscopy is pretty much your gold standard. Patients that have any of these go through repeated colonoscopies in their life. People without these inflammatory diseases will get them every few years. They're getting them every year, maybe even every 6 months, depending on how severe their case is. Blood work will also be done to monitor. We want to watch our fluids. We want to watch our H&H to make sure that we're not bleeding or if we're dehydrated. ESR and CRP are inflammatory markers. If these are inflammatory disorders, it kind of makes sense that they would be elevated. White counts, we know, can be elevated for infection or inflammation, so we see them elevated in this as well. Crohn's also has issues with vitamin B12 and folic acid. All three can potentially have positive guaiacs. And then UC and Crohn's will have issues with absorption and electrolytes. So a lot's going on. To care for these, surgery is an option depending on what's going on. This isn't first line thing by any means. Colectomies or colon resections, removing parts of the colon, are done in worst case scenario because of the damage that's done to the colon. So if they need that removed, the damage is significant. We will obviously want to avoid surgery as much as possible. We don't want people to have colostomies, but it is a potential thing that could very well happen. In terms of meds, we basically break it down. Steroids are used for acute exacerbations or flare-ups. Immunosuppressants and immunomodulators help control the disease. So this is going to be things like cyclosporin or methotrexate, which will make you prone to infection. And then immunomodulators like Humira. I don't want to pronounce the numeric because I can't. But that also puts us at risk for developing infection. So keep in mind you have an autoimmune disorder, you're immunosuppressed, risk of secondary infections is extremely high. They can also take things like sulfonamides as well. These are going to be the big things. But if you are on immunosuppressants or immunomodulators, infection and prevention is going to be significant. So caring for UC and Crohn's. We talk about patient education, but I promise you somebody living with Crohn's or UC is going to be educating you. So use them as a resource. Gather what works for them, store that away in your knowledge bank. We can try to teach them as best we can, but really they're the ones who are going to be teaching us. The biggest teaching that we can be doing probably is going to be about food and diet, because they already know what's going on with the disease. TPN is another thing that can be done with UC and Crohn's if we want to rest the bowel. Remember, TPN is given through a central line, so it avoids the GI tract completely, which allows the bowel to heal itself. If it's full of ulcers or swollen or inflamed, by bypassing that, it helps it promote healing. However, TPN has to be given how? Through a central line. So if they have a central line, high risk for infection. We have to be very careful. Prevent infection is going to be extremely important. And then helping with medication administration as well. For diverticulitis, we really want to keep these patients NPO. They get antibiotics to help heal the infection of the diverticula, pain medication as well. With antibiotics, same rules apply. Report these symptoms. Ciprofloxacin is a very common medication used with diverticulitis, as well as metronidazole. But with Cipro, any type of tendon pain, especially in the foot, we have to stop that. So we don't want, it's high risk for Achilles rupture. Like I mentioned, one of the most important teachings that will be done is about the diet, okay? So your patients need to know when to seek help if they're not feeling well. But they need to work with the nutritionist significantly. UC and Crohn's, when they are actually eating, we want high protein, high calorie, but low fiber. We want a low residue diet. What do I mean by a low residue diet?
Is that the amount of food that the body expels afterwards?
Kind of.
Is it like what's gonna get stuck to your bowels after?
Pretty much. And with low residue diet, typically the easiest way to think about it is going to be low fiber. So lower fiber foods are going to be your choice, especially during flares. No alcohol, minimize caffeine, small frequent meals. With diverticulitis, they get put on a clear liquid diet, then they start low fiber, and then they will gradually increase. It is also important with diverticulitis that we avoid things that could get stuck in those little pouches. So things like popcorn holes or seeds or nuts, they have a tendency to get stuck. If you've ever eaten them and had them stuck in your teeth, you know what I'm talking about. They can get stuck in those little pouches and cause an infection. So those patients with diverticulosis should not eat those foods, because then it can get diverticulitis, which is the infection. We also want to watch fat. And with these patients, we typically want a bulk forming laxative. We want them to pass stool regularly, not be constipated, not have diarrhea. So just something that gives them a nice, normal bowel movement. Complications of irritable bowel syndrome, peritonitis, things can leak. We don't want that to happen. Fluid and electrolyte disturbances, bleeding. Then we have that toxic megacolon. It does not move. It becomes very, very dilated and can result in either rupture and or death of the colon, which can lead to sepsis. So we want to prevent that from happening. Those are the big bad scaries. All right, let's do a poll question here. And I have to excuse myself because I need to take something away from my dog. Which one? No. All right, so we have diverticulitis. What should be included in their patient education about teaching? And that's going to be start low, progress to high. Indigestible material is not a good thing for diverticulitis, and we don't want to start with a high fiber diet. We need to work our way up there. All right, questions about the inflammatory disorders? Okay. All right, so celiac disease isn't considered an inflammatory disorder per se, but what happens with celiac disease is that your body cannot process gluten. It is intolerant of it. It's an autoimmune disorder that your body can't digest it, which if they come in contact with the gluten will cause diarrhea, general malaise, weight loss. They pass a lot of gas. They icky. It's just something that they feel by coming in contact with this wheat product. So in celiac disease, we have our little happy little people, our little villi that work and they pass things. With celiac disease, the gluten actually causes them to atrophy and not work and decreases the activity and the enzymes to process and digest the gluten. So they can't process it at all. Eliminating gluten in their diet resolves the issue and makes them feel better. People with celiacs, they know when they have gluten. So being gluten-free is not about being cool and trendy. It's about avoiding being on the toilet and feeling like crap. So typically, again, diarrhea, abdominal distension, muscle cramps. They can also have issues with anemia and pernicious anemia. So to treat celiac disease, again, or to diagnose it, we do genetic testing. They can do an IgA or they can do a biopsy. And again, once we remove gluten from the diet, their symptoms typically improve. I laughed the first time that I saw on my shampoo bottle, it said gluten-free. I'm like, who's eating shampoo? But just the absorption of it into your skin can be an issue for some people. So again, they know when they come in contact with it. There's also people that just have an intolerance of it in general, where it's not quite celiac, so they avoid anything with wheat. In terms of treatment, education is going to be key, and really working with dietary to understand what gluten is, where it comes from, and what foods to avoid, and how to switch things out and to make changes so that they're not feeling crummy. And then last but not least, upper and lower GI bleeds. So GI bleeds have a smell. You can tell when somebody has a GI bleed. Christina's nodding her head. She knows. They just do. You can smell them down the hall. If you are trying to figure out if it's an upper or lower, look at where the blood is reddest. Is it reddest coming out of the mouth or is it reddest coming out of the butt? That will tell you if it's upper or lower. Blood will be red closer to where the bleed is. So with upper GI bleeds, they're going to have bloody vomit, bright red bloody vomit, and black tarry stools because it has to pass all the way through the GI system. If they have a lower GI bleed, so something in their intestines, they're going to have hematochezia, which is bright red blood in their stool, but they're going to have coffee ground emesis because it has to work its way back up through the stomach. The blood does. So think of it as if the bright red blood is coming out of the mouth, it's upper. If it's coming out of the butt, it's lower. That's it. So upper GI bleed causes are going to be things like ruptured esophageal varices or an ulcer perforating, resulting in vomiting blood. Lower GI bleeds are going to be things like from ulcerative colitis or anything perforating in that area. I had a patient, bless his heart, who came in with a lower GI bleed, like he was just pooping bright red blood. I put him on the commode, and when we got him back into bed, I could see all the blood that was in there. And I'm like, oh boy, immediately started 2 big IVs, got the doctor in there. They took him to surgery. He had an arterial GI bleed. I mean, the amount of blood that he was losing was really, really crazy. There was some kind of malformation. But there was a lot. It was like somebody took a bag of blood and just like poured it into the commode. The treatment for upper and lower GI bleeds is going to be the same. We're going to stop the bleeding with clips and bands, and the meds are the same: protonic strips and octreotide. It's going to help decrease that pressure. The only difference is how we diagnose. EGD to tell us the scope to see where in the upper portion the bleed is, colonoscopy, and through the rectum to see where the bleed is. But those are the 2 big differences. So wherever the blood is coming out of that's bright red, that's where it's upper or lower. All right, let's do an ordering question real quick. So why would we want to obtain a health history first?
You want to figure out how long have they had the symptoms, if they even have appendix, because if they already have their appendix out, then we're going to know it's probably not an appendicitis.
Yeah, so by getting a history, we know what to look for or where to listen or what symptoms we should be assessing for. So first and foremost, we're going to get that health history. Then, because we do this first, we're going to look. We're going to inspect that abdomen and take a look at it. Then we're going to listen, and then we're going to touch, because we want to save the most painful part for last. And additionally, we don't want to stir up any sounds that we might not want. So, questions on any of that stuff? All right, let's do some poll questions then. Please ignore the last four options. Ignore upper, sigmoid, large, and anus. Those are not supposed to be there. Oh, let me do that. What are you doing? Okay. So, diverticular disease, because of constipation. So how do we treat them? What would we tell them to treat their constipation with? Increase their water intake. Absolutely. We want fluids. Increase their fiber. You betcha. Anticholinergic meds. That's going to be a no-go. That slows down peristalsis, so we don't want that happening. Stool softeners. Yes. NPO. No real reason to be NPO. So that's not something we would anticipate. Will they want to be maybe not eat as much because they feel full bloated? Sure, but we're not going to tell them not to eat. Okay. So we have GERD. What prescriptions would we anticipate? Antacids, sure thing. Histamine 2s, yep. Proton pump inhibitors, absolutely. Fiber laxatives, no, because they don't have any bearing on GERD. And we're not giving you opioids for acid reflux. Okay. All right. Vomiting, grossly distended abdomen and abdominal cramping. What are we thinking is going on? Because they haven't pooped in 6 days, and that is going to be an intestinal obstruction. So good job with that one. All right. So bright red streaking of blood in the stool. This would be, what are we thinking? This is hemorrhoids. Upper GI bleed would be melena. They'd have dark tarry stools. Iron supplements would also be something similar to that. If the diet was high in red meat, it'd have more of a reddish brown color to it. Okay. All right, so what happens when we are bearing down? When we bear down, that is going to increase the intrathoracic pressure, collapsing the large veins in the chest, decreasing cardiac output. So basically it's going to fill, kind of think of it like it's filling with air, So because it's filling with air, it's going to push everything else down. And that's why people pass out. Okay. All right. So peptic ulcer, what do we want to teach them about this? What statement would we say? And that's going to be, it's an erosion of the lining of the stomach or the intestine. Excuse me. Okay. And last but not least, I'm on a roll, Christina. I've hit share every time. All righty. So patient needs vitamin B12 injections. What are we thinking that they have? And that's going to be chronic gastritis. All right. What questions do you guys have about anything? Nothing.
Have you met the doctor, the new teacher?
I have. He teaches, he's from Utah. I know he does a lot with clinical. What clinicals he does, I don't know.
Okay.
He's very nice. He's very smart too. He makes me feel dumb.
You said it was Dr. Peterson.
Yeah.
He's the does the capstone stuff.
Yes. He does do that. I've been on committees with him. All right. Well, that is all I have for today because nobody decided to talk much. So we kind of flew through it. So I'll give you 45 minutes back of your day. If you need anything, let me know. Otherwise, I wish you all the best of luck and congratulations on your journey. Keep it up.
Thank
Good
you
luck
so
to
much.
you as well.
Thank you. Best of luck.
Thank you.
Thank you.